everyone, my name is Charlotte. I'm a CT2 in general surgery working in North London, and this is the second tutorial in the breast surgery topic. And today we'll be looking at breast cancer, specifically the investigation and the management. So within this tutorial we will be looking at triple assessment and then splitting that up into history and examination, imaging and biopsy, and then looking at the different ways of managing breast cancer. To start with, this is the same example case as in the previous tutorial, the overview. So again, a 55-year-old female presents with a 2-month history of a right-sided breast lump. She has no previous breast history but has a significant family history in that her sister has had breast cancer aged 50. She has a past medical history of hypertension and type 2 diabetes and has a high BMI. And previously she has taken the oral contraceptive pill and has been on hormone replacement therapy for 2 years. On examination, there is skin puckering but no significant asymmetry. The lump itself is in the upper outer quadrant of the right breast, is irregular and craggy but is non-palpable, and there are palpable lymph nodes in the right axilla. And just to repeat, the image down at the bottom there is a mammogram image, and you can see this area of density. That is the breast tumour, very likely with the history and the examination to be a breast cancer. Now, with any woman that comes to the breast clinic, they all must undergo triple assessment. Now, the only caveat to that is that if the clinical and imaging sections are deemed completely non-suspicious, then it may not be necessary to undergo biopsy or fine needle aspiration, but generally speaking, always breast cancer or breast pathology patients will undergo triple assessment. And triple assessment includes clinical, which is your history and examination, gaining any risk factors, gaining the patient's age; imaging, which is either ultrasound or mammogram or both, depending on the age of the patient; and pathology or biopsy, which is either a core biopsy or a fine needle aspiration, or in some cases an excisional biopsy, but generally speaking we would go for a fine needle aspiration or core biopsy first. And from these 3 parts that total the triple assessment, then you can gain a very, very confident diagnosis in most cases. Split up that triple assessment. So in the first section, the clinical section, we want a clear history and examination and risk factors. We spoke about risk factors in the previous tutorial, but just to briefly go over them, it is all about exposure to estrogen. And so we're looking at age of menarche, age of menopause, use of any hormonal treatments like a contraceptive pill or hormone therapy. Family history is very significant, age at childbirth and whether they breastfed, weight of the patient, and any previous breast, ovarian or endometrial cancers. Now, in terms of the history, there are a certain number of things that you need to gain that will give you a wealth of information about what this breast lump might be. So the palpable lump itself, when did the patient notice it? How did they notice it? Was it they themselves that noticed it? Was it their partner that noticed it? Was it because of the lump or because of any skin changes? And then, has the lump changed since they first found it? Is it increasing in size? Is it shrinking in size? Does it change at different times within the menstrual cycle? Has it actually stayed for longer than one menstrual cycle? Sometimes women will feel a lump at a certain point within their cycle. By that same point in the next cycle, it may have disappeared. So it's important to know if this is something that is persistent regardless of menstrual cycle. Then we want to ask about skin changes, and there's there's a good sort of breakdown of this in the next slide talking about examination. The skin changes, we're looking at any puckering of the skin, if there's any inflammation or any pigmentation or any eczematous changes. So ask the patient to describe how they feel the skin overlying the lump is, or in fact anywhere else on the breasts as well. Is the lump tender? Often people will say that breast cancer is a non-tender lump, which is the case in many cases, but there are always, slightly abnormal presentations or not uncommon presentations. So is there generalized breast tenderness? Is there tenderness over the lump itself? Again, does that tenderness change with the menstrual cycle? Next, you want to talk about trauma. We mustn't forget that fat necrosis is a significant diagnosis that people may feel a lump with, but will not turn into anything more sinister. So has there been any trauma to the breast that has led to the development of this lump? Then we want to look at nipple discharge. We want to know the colour, the consistency, how long it's been there for, is it becoming more or less frequent, is it blood stained? And then also nipple changes, so has the nipple retracted when it wasn't beforehand? If the nipple has always been retracted, that might be completely normal for the patient, so we're looking at changes rather than just, is the nipple retracted? We want to look at examination, and this is the image that I was talking about. I know it's lemons, but it does have a good way of showing you what type of things you're looking for. So you're looking for any asymmetry. So between the two breasts is one supposedly normal, and the other one you can see a lump, or you can see an indent, you can see puckering of the skin, the peau d'orange as we describe it, the orange peel skin. Is there a retracted nipple on one side and not the other? Can you see any dimpling? Can you see any nipple discharge? And all of these different things are something that you can see purely on inspection. You then want to make sure that you ask the patient to raise their arms above their head, as well as tensing the pectoral muscles to see whether the lump is tethered to either the skin or to the muscle. Another thing that would be that would go in line with a more sinister diagnosis. Once you actually come to palpate the lump, you want to be assessing the size, the site, the shape. Is it a smooth contour? Is it very craggy? Is it nice and uniform all the way around? Is it very inconsistent? Can it move around, or is it fixed to either skin or muscle? Tenderness, and then also looking for lymph nodes in the axillae and in the subclavicular region. And then nipple discharge. If the patient is describing that they have nipple discharge but it's not evident, you can ask them to express or try to express any discharge. You can take a sample of that to send away if there is any concern regarding that. And then the last things to do in terms of examination is to assess whether there is any evidence of spread. So lymph nodes is the first stage in that, but also the breast cancer can commonly spread to bone, lung and brain. Brain is obviously very difficult to assess just from examination, but you can auscultate the chest to see if there's any lung metastases, or to see if there's any differences in what you expect to hear. And you can also assess for spinal tenderness just by tapping down the spine, and that might point you in a particular direction. So next you're going to go for your investigations, and within the triple assessment, the investigation that is key is imaging. The two imaging modalities are ultrasound and mammogram. Younger women have breast tissue that is too dense for effective mammograms, so only ultrasound is done in younger women, and the age of this is variable between trusts, but somewhere around 30 to 35 is usually the cutoff between ultrasound only or ultrasound and mammogram. So in older women, it's not only mammogram, it's both, which gives you a more accurate diagnosis. Following on from this is generally the radiologist that is doing the scan that will then decide the best type of biopsy to take. So a fine needle aspirate is where a small needle is inserted, and then aspiration is taken from the lump. Generally speaking, if there's a breast cyst, the fine needle aspiration might be very useful, but if it's more of a lump, if it's a dense lump, a core biopsy is a better way to go. And the idea with many breast clinics is that it's a one-stop clinic, and what you can do is come on the day, be seen by a breast surgeon for your history and examination. You can then go straight to imaging to get your ultrasound or mammogram and biopsy at the same time if deemed necessary. And then from that, you obviously won't have the biopsy result, but the imaging result can often be either very reassuring or very suspicious or somewhere in between. So the patient can then be counselled afterwards as to whether or not we are waiting on the biopsy for a more sinister diagnosis. So let's talk about management. So your patient has a confirmed breast cancer. Now there are obviously lots of different types of breast cancer. The two main types are ductal or lobular. And the important thing that comes with the biopsy, not only just what type of breast cancer it is, but also the hormone receptor positivity or negativity. So we're looking at the estrogen receptor, progesterone receptor, and the HER2 receptor as well. So in terms of breast cancer management, some patients, depending on the size of the lump or the size of the breast, might have neoadjuvant drug therapy before going for surgery. And the aim of this is to shrink the tumour to allow for a less radical surgery. So there's either chemotherapy with your cytotoxic drugs, or there's endocrine therapy, and it's the endocrine therapy that is dependent on whether the patient is ER, PR, or HER2 positive or negative. Like I said, the patient may or may not have neoadjuvant drug therapy, but the majority of breast cancer patients will have some sort of surgical management. Now, whether the patient needs a mastectomy or a more breast conserving surgery like a lumpectomy, wide local excision, depends on the size of the lump in comparison to the size of the breast, and also on patient choice. If there is a large lump in a small breast, a wide local excision isn't going to work because there won't be enough breast tissue left to reform a breast afterwards. Similarly, if there is a large lump but in a very large breast, you may still be able to do a mammoplasty to create a normal looking breast following the removal of the lump. But we must always talk to the patient about what they feel. Even if it is a small lump, some patients will just want to have a full mastectomy to try to reduce any risk of further lumps in the future. As well as the lump itself, you also need to think about whether there is any spread to the axilla. Now, these patients, we will often know if there were palpable lymph nodes at the time of the triple assessment, then sometimes a biopsy can be taken of a lymph node that is palpable. But if we don't know, then something called a sentinel lymph node biopsy is a very good way to try to get a lymph node without doing a full axillary clearance, which is removing all of the axillary nodes, which is a much more invasive procedure. So a sentinel lymph node biopsy is finding the first lymph node that the drainage from the breast goes to. And usually that is with a blue radioactive dye that is injected just via the nipple, and then the radioactivity is picked up as the fluid drains via the lymph vessels to that first lymph node. And just that one or maybe one or two lymph nodes are biopsied, so a much less invasive procedure than a full axillary clearance. If that lymph node then comes back as positive, then you may have to go back for an axillary clearance, but it might save you the total clearance if the biopsy is negative. And then, following on, rather than an actual cancer surgery, but the reconstruction is a very important part of breast surgery and breast cancer management to try to improve the patient's outlook of themselves, of their breast. It's very disfiguring having to have a mastectomy, and it's a big psychological impact on a patient that they may not have what are so-called normal breasts in the future after their operation. So reconstruction is a really big thing to consider and to talk to patients about very early on. And we'll talk about that a bit more in the next slide. Most patients will go on to have radiotherapy post-operatively, and that is to reduce the risk of local spread. And then following on from that, the patient may or may not be started on adjuvant drug therapy. So again, depending on the type of cancer, they may have adjuvant chemotherapy, they may have biological therapy with some of the monoclonal antibodies, they may have endocrine therapy, again depending on that receptor positivity or negativity. And then also bisphosphonate therapy has been shown to improve disease-free survival in postmenopausal women. So these are all things to be considered. And all of this is not only with the breast surgeons, it's between the breast surgeons and the oncologists and the breast cancer specialist nurses and the radiologists and the pathologists. It's a full MDT approach from the offset. So then we'll talk about reconstruction. And reconstruction can either be primary, which is at the time of the cancer surgery, so at the time of removal of the lump or mastectomy, or secondary, where the cancer surgery has happened at some point in the past, and then they go for a second operation for the reconstruction. And the reconstruction can either be implant-based, where an implant is placed either in front or behind the pectoralis major and minor muscles, and where this is placed in relation to the muscle often depends on patient choice, on patient activity levels. I had a patient once, a young patient, who was having a prophylactic mastectomy for a very strong family history and a positive BRCA gene, and she was a dancer, so she had her implants pre-pectoral, because having them behind the muscle would alter the shape of the implant upon movement, and she was obviously moving a lot as a dancer, so it's, you have to consider a lot of patient factors. You can also have a therapeutic mammoplasty, which is where the lump is removed in a particular way so that the breast can be reformed to make it look as if the lump was never there in the first place. So that is not necessarily using an implant or using any sort of other muscle. It is purely just using the breast tissue to reform the breast into a more normal shape. And then we have the flap reconstruction, and we can either have free flaps or pedicled flaps. So the pedicled is where you take, I've got pictures of this on the next slide so it'll make a little bit more sense, but the pedicled flap is where you take a muscle and you keep it on a pedicle, so you're not completely removing it and placing it on the breast, you are swinging it on its blood supply to the region in which you want to use it to form a breast. Whereas the free flap is completely taking away a portion of muscle to then move it to the area of the breast to reform that. So just to explain, so we've got the deep inferior epigastric perforator flap, or the DEP flap, and that is taking a portion of the deep inferior epigastric artery and vein and a portion of the lower abdomen and moving it to plumb in the artery and vein to the internal thoracic artery and vein in the chest, and using that to create the breast. So that is a free flap. You've then got two different types of pedicled flaps, the latissimus dorsi, which is the muscle that comes down into the back, and it's kept on its muscle origin but brought forward to form the breast. And then the transverse rectus abdominis muscle flap, or the tram flap, which is where one of the abdominal muscles will again be brought up on a pedicle to form a breast. And these tend to work really well. So, last thing, we're going to do a sample SPA. So, triple assessment includes history examination and surgery, history examination, imaging and chemotherapy, history examination, biopsy and surgery, history examination, imaging and biopsy, or imaging, biopsy and surgery. So have a think for a moment which one you think is the correct answer. And hopefully you have all picked D. So history examination is your clinical part, imaging, and then biopsy to give you the 3 aspects of the triple assessment to get a confident diagnosis. In this session, we've looked at triple assessment, which is clinical, imaging, and biopsy. We've then looked at the management, including surgery, chemotherapy, radiotherapy, and endocrine therapy. And we've also looked at different types of reconstruction, be it implant-based, mammoplasty, or free or pedicled flaps.